Good morning, everyone, and thanks for joining us today at this event, addressing Losing the Stigma, Addressing Obesity Through Empathy and Healing. This is the first event in a series that we're running as part of a larger programme on obesity at Economist Impact. I'm Ellie Vaughan, and I'm a Senior Research Manager in Economist Impact. And at the heart of the programme that we're running is an obesity response index. So we're looking at how all 50 states and 20 countries globally are responding to obesity, both in terms of policy and provision. So I wanted to highlight to you, as we find ourselves in Texas today, that so far our research has indicated that of the 50 US states, only 29 have any kind of obesity strategy or action plan. So that indicates to me that there's a real lack of strategic direction in obesity prevention and management in the US at the moment. And of the states that do have plans, we also found that a lot of them weren't comprehensive enough. So they weren't covering the full remit of topics that we need to see covered, or the full range of different factors that are contributing to obesity. And a lot of states had a plan, and they have not updated it since, and things like this. So we're really seeing a lack of policy and therefore a lack of action, which is what we really need to see. Today, our discussion is going to focus on stigma, which is a really important issue. Stigma is more than just, dismissing it as hurt feelings or something like this. Stigma has real physical and mental implications for people living with obesity. We know that people who experience weight stigma are more at risk of developing depression, anxiety. They also may engage more in disordered eating and may be reluctant to seek treatment and support for their obesity, but also other health conditions. So it has real profound impacts on people, as well as social and economic impacts, as we'll discuss today. But thinking about those 29 states that do have an action plan, only 7 of those address stigma in their action plan. So again, we see that within this inadequate policy framework, there isn't stigma being addressed enough. And how many states address stigma through discrimination legislation? Obesity through stigma through their anti-discrimination legislation? 1, Michigan. 1 state has weight listed in their anti-discrimination legislation. How wild is that? So that means that we don't have protection in policy, we don't have protection in legislation either. So this is something that's really important on a multiple different layers. And one of the parts of this program is actually a video series where what we're trying to do is to tell the diverse stories of people who are living with obesity. So we're trying to show that there are all kinds of people who are living with this disease, and that this disease affects them in a multitude of ways, and there's a load of different factors that are contributing to their ongoing journey of living with obesity. So today, I'm really glad to be premiering first in this video series. And so we're going to hear today from Lorenzo, and this is our video series, Living with Obesity, Stories Behind the Statistics. Thank you.
Meet Lorenzo Lewis, an Atlanta-based entrepreneur and one of the 14 million Black Americans living with obesity.
So I'm from Little Rock, Arkansas, deep southern state, obviously cornering Mississippi, Louisiana.
You meant business on that picture, didn't you?
I lost my dad, and that's when my overeating started. Like holidays, if I remember, my uncle was big on like barbecue meats, pork, cheesecakes and pies, Southern traditions with food it really runs deep. Bless us nonetheless, God bless us food for the nourishment of our body. In your name we pray, amen.
Amen.
It has really been an underlying way that we connect with each other. But not really understanding the impact of how it can harm our health in a long term. I think a lot of people around me have lost people to health issues, particularly in the Black community, heart disease, diabetes. So it's a common conversation.
As Lorenzo's understanding of his health has developed, he's been able to learn what works for him and make changes that actually fit his life. In the last year, he's lost close to 100 pounds.
I was up to like 584. I was almost 600 pounds. You know, like that's a big change, but there was a lot of weight I was carrying, obviously.
Lorenzo's wife and daughter are also living with obesity and trying to find healthier ways of living.
There you go, good job.
Definitely my daughter, I could tell that early on some of my food struggles may have impacted her. I started boxing and working with my trainer. I work out every day now because it helps me to relieve stress. That in itself has been something that I've been conscious about with my daughter and with myself. That has been motivating for me and my wife to continue to be conscious about our own journey as we teach her. I think the proudest memory that I would have of my journey would be sticking with it even when I failed at it, because obesity is really a disease. You have to stay on it and you have to be advantageous about trying whatever you need to do to get to a healthy future.
Thanks, everyone. I've watched that video a lot of times now, but it still always gets to me. I really love it. So I'd like to say thank you to our sponsors, Lilly, for making that video possible and the whole series, the research that we're doing, and also today's event. Now I'd love to welcome up on stage our panelists. So we have Christy Gallagher, Associate Director for Research and Policy at the Stop Obesity Alliance. Amber Hewitt-Garcia, Trustee at the World Obesity Federation. Scott Cahan, Director of the National Centre for Weight and Wellness. And Sylvia Gonson-Bowley, Executive Director of Medical Development at Eli Lilly. So I also wanted to get a sense of the audience here as well, because I know we've got a lot of different people in the room. And I just wanted to do a quick show of hands in terms of how many of you feel like you've witnessed weight stigma in the media or in conversations you've been part of. Just raise your hand if you see. Okay, that's fairly comprehensive then. Okay, that's a good start. That's showing that this conversation is needed. But on the flip side of that, how many of you would feel confident in advocating for yourself if you are or were living with obesity in terms of getting treatment, getting sort of access to management services and things like that? How many of you would feel confident in a medical setting about talking about obesity if you're living with it? Hands up. Okay, so a fair few of you, but not as many as have seen weight stigma around in the world at large. So that's an interesting thing to consider here. But I wanted to come to Amber first, because Amber, you work a lot in the advocacy space and supporting people living with obesity and working on policy to try to get better support, etc. And I was wondering, could you just talk us through what some of the most common misconceptions and sort of stigmas around obesity there are?
Yeah. First, thanks for having me here today. I think the most common misconception about obesity is that it is a personal choice. But the reality is that it is a chronic, complex, lifelong disease. Some people, I think, have an emotional reaction to this word, but I say it is often relapsing. So my high weight, I had a BMI of 69, and now I'm in the mid-20s. And when I tell people I'm still living with obesity, I think they finally see that weight is a symptom of that. Like what you see in front of you is actually a result of care. And that, yes, the personal decisions that we make impact our health. That's true about any chronic disease. But we're not going to exercise our way out of the obesity epidemic. There are treatments that work. And so we have to shift the conversation to including personal responsibility, but how do we get people access to real care?
Yeah, absolutely. And Scott, as a physician, I know that you said in interviews that one of the hardest parts of your job is tackling misconceptions. So to get our conversation off on a good start, could you talk us through some of the key causes and drivers of obesity, both at an individual and a broader level?
Yeah, so at the most basic level, the obesity epidemic is driven by a mismatch of our genetics, and secondarily biology, and our environments. So we evolved over millions of years as a species in times of very minimal food availability and a very high need for physical activity, whether to get food, whether to run away from predators, and so forth. And in a evolutionary blink of the eye, just in the past few decades, our food environment, our physical activity environment has changed entirely upside down. So now there's food everywhere. In general, food is very cheap. In general, food is very heavily marketed, especially the most unhealthy and high-calorie foods. And physical activity is not all that necessary. I mean, sure, we can work hard to go to the gym sometimes, but even then, a hard workout in the gym for an hour is pretty minimal compared to the 8, 10, 12, 14 hours of physical activity that our ancestors had on a daily basis, whether working in the fields, whether, scavenging for food, things like that. So we have a biology that is adapted for times of minimal food availability, lots of need for physical activity. We have now an environment which is the exact opposite. You put those two things together, and that is what has underlied most of the rise in obesity throughout the world, and certainly in the Western world. And there's all sorts of individual factors as well, but that is the central underlying piece as far as we understand.
Yeah. And Amber, I know you do a lot of work in schools and lots of different settings. And I was just wondering if you could talk us through, how does weight stigma and sort of prejudice and bias show up in different settings?
Yeah, I think for schools primarily, thinking about the primary customer of kids, when you think about weight in that setting, it is actually probably weight-based bullying and how children feel part of a school. And children learn from adults. So the things that they say to their peers has been modeled to them either explicitly or implicitly, either by not saying something or maybe having that encouraged. So I think that shows up a lot. I think in healthcare settings, bias isn't just the things that a medical provider says to you, it's the environment. Or do you have a waiting room that has chairs that accommodate bodies of size? Do you have chairs without arms? Do you have a scale on a place that is private? Or giving an option to not actually be weighed, or the medical equipment can accommodate a person of size. And then I think the final place it shows up is really in the personal interactions. I think the most insidious stigma is the things that we believe about ourselves. And so even how you advocate for yourself, no one will advocate for you more than you. And so peer to peer, like correcting each other when we say things that we know are not true about living with obesity. So I think personal relationships are where it shows up most.
Yeah, that's a really interesting thing, because that's the thing, is that it does pervade people's whole lives if you're living with obesity. It's not just that it will be confined to sort of specific moments. But actually, I did want to talk specifically about healthcare settings, because I know that a lot of people living with obesity report a reluctance to seek medical support, either for their obesity or other conditions, because of the experiences they have. And I know Sylvia and Scott, you're both physicians. And Sylvia, I was wondering if you could talk us through, how can we challenge misconceptions about obesity amongst healthcare professionals and actually enable them to have conversations with people living with obesity that are constructive, appropriate, and empowering?
Yeah, I love that and appreciate everything that the panelists have said so far, because it's so spot on. When I think about this question, I fancy myself a closet poet. So I think about 3 A's: awareness, assessment, and then adequate education, because so often physicians and in the healthcare setting do not know what you don't know. And as we saw here with people raising their hand, that weight bias is so embedded into our implicit mind and subconscious doctors fail to realize what they're bringing into the table. And we've seen that. So I know Scott is at GW. At GW, I've volunteered for the past 3 years. They actually have a course for medical students where they use something called the implicit association test, right, and for weight. And every year, it's at least 70% of the students did not know they had weight bias before, and they are always very surprised afterwards. And now this is this generation, which are much younger, that have been exposed to body positivity and all the other things that we've tried to do to dispel obesity myths. So imagine an older generation. So I think one of the things that we really have to do is make sure that our colleagues who are a little bit more senior, such as myself, like that we actually are aware that bias exists, and even if you don't think you have it, take this test and see if you have it. And then after that, I really think time-sensitive education that is really relevant, kind of like I'm giving all my panelists shout out. So like for Christine at the Stop Obesity Alliance, when I was practicing primary care, I really relied on that because they were really like time-sensitive interventions that made sense right at the bedside that you could use. So that's my thoughts. Awareness, assessment, and adequate education.
Yeah, that's a great way to think about it. I like that framing. And Scott, I know that you lead, multidisciplinary teams. So you're dealing with people in lots of different sort of fields of medicine and different sort of healthcare professionals within that. And how do you ensure that your team are having those sort of quote unquote good conversations with people, but also implementing those kind of timely conversations and taking advantage of those moments?
Well, I'm lucky. I'm in a great situation where I have a large team of doctors and dietitians and psychologists and exercise physiologists who mostly have come to me with a great background in obesity, understanding obesity, being empathetic about people who have obesity, and we work together great. And so it's really a great situation. I think maybe the more important question there is, how can that happen outside of a dedicated clinic like this? How does that happen? How can that happen in general primary care or in non-obesity specialist settings? And I think key there is to see patients as people. And that's not very common when it comes to doctors and other healthcare professionals dealing with patients who struggle with weight. Often they see the weight, but not the person. Often they see the weight as a personal failing of the person, or the person being a bad person or a bad patient, rather than coming to the table in a way of supporting the person, and by extension, the whole person. So I think that's something really important. That's going to start with education of physicians and other healthcare professionals, and that's something that has long been absent in medical schools and other healthcare professional training programs. It is something that we are making real progress on, but still really far away from where it needs to be. It's not an easy thing to change medical school curricula. Very, very difficult. Even till now, the testing for doctors when they graduate medical school and when they get their licenses doesn't include testing on obesity by and large. We did a study that we published a few years ago on this. So there's not even a drive for the policymakers at universities to include more obesity education in the curricula. So these are things that we've been working on for quite a while, and again, making progress, but slow progress. I think that has to keep happening and needs to rev up to really see things move forward.
Yeah.
So, can I just add?
Yeah, of course.
So we, Scott and I actually worked on this about a decade ago, where we developed a guide called the Why Wait Guide, and also followed that up with another one called the Weight Can't Wait Guide, which was really for that primary care setting for providers to sort of, ask the question, is this a good time to talk about your weight? Would you like to talk about your weight right now? And sort of leaving it up, because it's such a sensitive topic and so many patients have been stigmatized against. And so it's really, it's a tool that's there, And then the next step is really, if the patient says, no, I'm here for strep throat, this is what I want to be treated for, that, it leaves the door open for the provider to say, we'd love to have you come back. I have some ideas of things that some tools in the toolbox that we could use. And then sort of leaves it for the patient. And we've learned that when that door is opened, more patients will come back and seek that treatment because they found a caring provider who asked them, is this the right time?
Yeah. And Amber, from the patient sort of advocacy side of that, how do you approach that in terms of sort of working with healthcare professionals? And, to Scott and Christy's point, those primary care physicians who are usually the first port of call and are actually really pivotal in terms of people's access to treatment for obesity.
Yeah. Oh, I tell anybody living with obesity, they all have some level of medical trauma that even if they're not aware of it, they get a nervousness. I think to Christy's point where I have a cut on my arm, or they're going to tell me my BMI is too high. You can fire a doctor. You can go through all of those things and also realize this person's not a good fit for me. And finding someone who engages with you in a way that that you are treated with dignity and respect is most important. So you may have to switch providers, but obesity is a complex disease, so you're gonna have a whole medical team. So I have a rheumatologist, I have a plastic surgeon, I have a mental health professional, and I have a great primary care physician, but all of them are addressing things that are part of what it's like to live with obesity. But I think as just a general education of the public, I think changing the way we talk about obesity impacts what we expect out of our medical providers. So I think specifically how we're talking about it, using people-first language. We're living with obesity. We are not our disease. So when you see obese woman or obese man, that is, it's stigmatizing. And you think of the disease first. We are people first, as Scott said. So seeing that, and that matters. The words that we use matter, and how we talk to ourselves. But I think the second is the imagery that we see. Don't put a headless image on an article. It implies that you should be ashamed to have an identity associated with a larger body. And then people living with obesity, we soak all those things in, and it shows up in healthcare settings. So the education is also a public education, and how you develop your own advocacy and how you feel when you walk into a medical setting.
Your point about imagery is really interesting, actually, because having worked on a few obesity programs now, the challenge of finding stock imagery that is positive and isn't sort of, again, defining people by their disease, but also things like trying to find sort of images of someone in a workplace that's successful who is also visibly living with obesity. It's really, really challenging to find these kind of positive images. And I did want to ask you, Christy, about we talked about how weight stigma shows up in lots of different settings. And the workplace is somewhere that can either be terrifically harming or very helpful in terms of people living with obesity. And I was just wondering what your thoughts are around HR, but also things like thinking about medical directors, wellness directors, things like that. What sort of role do you think they could play in terms of positive aspects of living with obesity and helping their employees?
Yeah, so one of the things that we advocate for or try and explain is that wellness programs are not the same thing as obesity treatment, coverage. And so it's wonderful to have wellness programs. All employers, large and small, should have some type of wellness program. But when a person living with obesity might not feel comfortable going to the workplace gym and joining the 5K race and those kinds of things. It's important to have the gym there. It's important to have the healthy food or the access to healthy food, salad bars and all that. It's very important. But what we really advocate for is an actual comprehensive obesity benefit that is offered by the health plans that large employers offer, or state Medicaid, state employee health plans, federal government employee health plans, and so forth. And in that comprehensive benefit, we really advocate that it needs to be all treatments, so not just medication, not just surgery, but everything from nutrition counseling to physical activity, and then the medications that are FDA approved, as well as surgery. But we also advocate for maintenance. So people who, like Amber, have been through the process and have lost a significant amount of weight, but are still living with obesity. And then if they, changes happen in their life or their health changes, they need to be able to have access to maintain that treatment.
Yeah, and that's that sort of sometimes problematic for some people, as you highlighted there, Amber, in terms of the relapsing aspect of it, that it can't just be that someone hits a certain BMI and then you cut them off from all treatment, because it is a long-term chronic condition. And we've talked about, how we can sort of help to address stigma in terms of, making healthcare professionals have more positive conversations, workplace environments, but how can we also work with people living with obesity to empower them to be able to, overcome that medical trauma and walk into settings with their head held high to talk about whatever the health complaint they want to talk about on that day is. And I know, Christy, you've worked on a lot of sort of practical tools and things like that. What are your kind of top thoughts on how we can empower people living with obesity to have all manner of conversations in a healthcare setting?
Well, I think a lot of it is education, right? So we've touched on that a lot, but educating the public and everyone to know that obesity is a disease and it's not your fault. And so you should be empowered to be able to, find a healthcare provider who will treat you with respect, and also be interested in working with you on whatever it is you want to work on. So I think that's really important. I was with some folks over the weekend, and there was a lot of sort of conversation there about, making sure that patients don't feel like it's their fault, and then how can healthcare providers have sort of these welcoming settings for them to come to. So, and then I think also sort of getting back to the employers, having employers that offer these benefits, that have treatment available. But I'll be honest, we've been working on this I've been working in this field for, close to 15 years. The last 2 years, with all of the advent of the new medications on the market, have really helped us as far as bringing more light to the fact that it is a disease and that it is treatable. And so I think more and more people are interested. I have more and more people, even friends, colleagues, friends of friends saying, I'm really interested in this. Is there something that, my doctor recommended this. Can I talk to you about it? So there is definitely a lot more conversation out there, more articles being written. And I think we're actually on our way towards a society that's going to eventually sort of treat this more as a disease that's treatable.
Yeah, absolutely. I think it's really interesting that both you and Amber have talked about switching providers. And I think that's such an important, empowering step, because honestly, in my experience of the healthcare sort of system, I've only ever come across that when having a baby. When pregnant, I was told, you should choose a midwife who you feel comfortable with, and you have the right to say, I want to see anyone else. But we don't extend that to other parts of the health system. We don't say to people, actually, if that healthcare professional is not having the right conversation with you, if you don't feel like they're treating you as you can have that conversation, you can have that power. And Sylvia, I wanted to come to you next, because Christy alluded to it as well. How do we help to empower people living with obesity to identify the goals that they want to achieve that are not just based on the symptom of obesity that is weight?
Exactly, yeah. I love that. And so the way that I like to frame it and think about it, there is happy weight and then there's healthy weight, right? And happy encompasses, and we don't talk a lot about happiness, like we've talked on this stage even about education, right? But there is also an emotional aspect to this work that we do, and a lot of this bias is driven by emotional experiences that people have had. So one thing I empower patients to do, and I do a lot of work, especially within the Black community in Montgomery County, Maryland, where I live. I'm a part of the Black Physicians Healthcare Network, Education and Outreach Partners. So one of the things I've done is made these cards where, number one, from a healthy weight perspective, I'm sure we're going to talk about BMI because everyone's up here. So really making sure that BMI is only used as the starting point of the conversation, and then that physicians and patients need to be aware that there are specific adjusted BMI charts based on your age, based on your biological sex, based on your race and ethnicity, based on whatever comorbidities you may have. So I like to make sure patients know that first and foremost, and then that's just a start, but then individualizing it, knowing how much fat you have. So obesity is actually a disease of adiposity or excess body fat and not just weight as we've done it. So you really need to know how much you actually have, then where it is, because where location matters, kind of like real estate, right? So it matters. And then you also need to know what other comorbidities, we call them, or other obesity-associated health conditions you have, really metabolic health conditions. Because when you say it's a chronic disease, like for me, I come from a family with obesity. Pregnancy was actually my obesity trigger, and I have lost 60 pounds and live with it. But I find that there are other metabolic health challenges, right, that are associated with that, hypertension, diabetes. So having to really make sure that we're adequately assessing those, even if you have a normal weight as well. And that's the healthy weight. And then happy weight, what are your lived experiences? Because two people can weigh the exact same thing, have the exact same height, and interpret it completely differently. So really making sure we're having that conversation. Why do you feel that way about that weight? And where do you want to go with it, and what tools can I support you with?
Oh, great. I love the simplicity of the happy weight versus the healthy weight, and those things also aren't in opposition. You know, they're complementary and helping people to identify their own goals. Did you want to add something, Amber? Yeah.
No, as you're wherever you can maintain and feel like you can live your life, not controlled by your disease, is where you should shoot for. And I think thinking about other health outcomes. So we talk a lot about weight, but I say, if you ask my mom what her ideal weight is, she's like, whatever weight I can get in the floor and play with the grandkids, that's what I want to weigh. And I don't know it until I'm there. So it's just thinking about what the lived experience is of what we're trying to achieve in addressing obesity.
Yeah, definitely. And Scott, I wanted to ask you next, because Christy's already talked about the range of treatments that are available for people. And I was just wondering, in terms of how do we empower people to be aware of the full range of treatment modalities and how to have conversations? Because again, a lot of people living with obesity, they experience that they go to the physician and the physician wants them to start from diet and exercise and work through a whole program. They won't just let them sort of tell their story and tell their experiences, etc. So how do you do that in the sort of setting that you're working in terms of making sure people are aware of the full range of treatments and empowered to ask for what they know will work for them as well?
Yeah. You know, I think it's more challenging than it might seem. Part of it gets back to what I mentioned earlier about a better trained workforce of physicians. That's ideally where it should come from. You should be able to go to your doctor, whether you have arthritis or whether you have obesity, and know that the healthcare professional in front of you is schooled in treating that condition and is going to give you advice on the range of treatment options and the benefits and drawbacks of each, and then we'll work with you on the direction that you decide to go. And that's just not the way that it is typically in the world of obesity. So we need more training of our healthcare providers. And then I think we also need better education and information for patients. Most people don't know that there are effective treatments for weight management. They fall into this diet or that diet. They fall into this, supplement or pill or whatever. And I don't think we do a great job at educating people in what the real science is and what the real medicine is. I think there's a whole lot of competitors that trying to make money for themselves that do a pretty good job at it, whether trying to sell their diet or trying to sell their supplement or their magic program, and they do a good job with the marketing of it. I don't think we do a very good job at marketing real science and evidence-informed, healthful living. And it's not an easy thing. I think it has to in part come from government. I think it in part has to come from industry. I think it in part has to come from policymakers and otherwise. But I think we need to hit this from a number of different angles.
I think I saw recently that 90% of people living with obesity have never sought treatment for obesity. So that's a large percentage of people out there that haven't even thought about it or approached the topic. So.
And 50% of people living with obesity never get a formal diagnosis either. So it's one of those chronic diseases where we expect people to diagnose themselves, and that is you don't get to the treatment conversation if you never have a formal. I want you to understand that you are living with obesity and this is what it means. I think one group that I would add to Dr. Kahan's list there and the ability to change things, though, are people living with obesity. And the number of people who have reached out to me personally, I make a joke that I talk to 1% of everybody who has bariatric surgery in the United States every year through Instagram. And I'm like, well, do the math. I might actually, people want to talk to other people who have been through what they have been through. And when you tell your story, you take that, you take the stigma out of it, but you also get an education through it. Like I've actually had metabolic surgery 3 times, so I've had 2 revisions, and so the procedure where I had the most effective results was a SADS. The number of people who have even had metabolic surgery who know what that procedure is really low, and so telling that story does influence. They're going to go to their doctor. I mean, the number of people who have said, I finally talked to my doctor about it because you're open about your story. So storytelling really matters, and I think folks like Lorenzo telling his story and how culture is part of that, how your environment, the things you experience as a child, we all have unique stories, but they are going to be part of that in sphere of influence.
I think and that's so true, because one of the things that there's sort of this narrative now, I think, predicated by the launch of obesity medications, that there's going to be this sudden rush on the health system's going to be completely overwhelmed. And Christy, that just, based on the statistic that you just shared, that's just not the reality, is it?
It's not. And, when you're trying to estimate exactly what this is going to cost the healthcare system, we overestimate and continually overestimate. And so even for a benefit like intensive behavioral therapy, which is similar to something like a program that you get at the YMCA or like a Weight Watchers type program, even that, the occurrence of it is very small in what people are in, like sort of official programs that are covered by insurance.
Yeah. And Sylvia, I wanted to come to you because you mentioned earlier about the equity considerations here, and we saw in Lorenzo's story about how often his conversations with people in his community are around people living with obesity, but also other health conditions. And certainly in the research we've been doing so far, we see that obesity rates in the US are quite high, but amongst Black and other minority groups, they're even higher. So I was just wondering, what do you think we can do to, we talked broadly about empowering people and ensuring that they know that they have the right to access different treatments. Mm-hmm. How do you think we can address that, specifically thinking about the equity considerations here.
Yeah, well, I'm happy you brought that up. It's a very important point, and I think that was one of the most shocking things for me when I began to specialize in obesity about 10 years ago, was realizing that Black women have the highest rates of overweight and obesity, but are underrepresented when it comes to being even offered treatment. And so there's like a recent abstract from Lisa Cooper that she presented at AHA, that showed that even when Black women have commercial insurance, there's the rate of being offered the prescriptions was 1%. And so we know it's not just about pharmacological treatment, it's the whole treatment of the patient, but these are very powerful tools as well. So again, I think it's multifactorial as well. There's cultural beliefs, right, about a lot of times when I go to speak to people, and I don't even have to go in the community, I just go in my own house, right? It's like, girl, I look good, you know what I mean? Like I don't care, I want these curves, you know? So really moving for certain groups and demographics, we have to move the conversation beyond just weight. And what I love about Lorenzo's story is how he pointed out how the association was with other health conditions as well and the complications. And so I think, again, framing it in that healthy weight, happy, healthy weight, that this is more than just about the number on the scale is so important. But then it's moving it beyond the individual, right? So I move away from even the awareness that these tools could help, but it's also advocacy too. Advocacy is key to access. And so one of the things, we've probably all heard about is the Treat and Reduce Obesity Act, and that actually made some traction last year. We were all excited in July, it went through the House and Ways Committee, but now we need to keep moving it forward because the key to access is economic empowerment, when you actually see these go hand in hand too. So I think there are many levers when it comes to equity that we can move, but the first step that I think that is controllable, especially on the individual level, is making sure patients are aware and that we destigmatize needing other treatment. Like, you don't have to earn your right to getting these other treatments, because food, exercise, nutrition changes may not be enough because of the genetics, and so you may need more, and there's no shame in that.
Yep, absolutely. And we've talked about the way that stigma and misinformation is prevalent among lots of different groups within society, et cetera, and the different areas it shows up in. And I talked earlier about how, there's only 29 out of the 50 US states that have an obesity action plan or any kind of strategy in place. And Scott, I wanted to hear, as someone who's worked in policy a lot, what's been your experience of sort of working with policymakers? How aware are they of the real causes and drivers of obesity, and what impact does that have on trying to make effective policy?
Yeah, they're aware just as much as the general public is aware, which is to say very little. I mean, policymakers are, they're regular people with a lot of power in a lot of ways. And so they need education and guidance if they're going to best understand what's going on and then be able to make policy changes as a result. I'll give you an example. So this was almost 20 years ago. I was at an event at the Kennedy Center. I was introduced to one of the most powerful senators at the time, one of the most liberal and one of the most powerful. And I was introduced as a doctor who works with obesity, and he shook my hand, and the very first thing he said was, "So how are those fatties?" And I was just so taken aback, and I didn't say all that much. I just sort of went along with it. I was so shook by that. At the same time, over the next few years, as I continued to talk to him and interact with him, he became a pretty great advocate of moving policies forward on obesity as he learned more and appreciated more about what it is. So education of policymakers is really, really important. And it goes all the way from the top, from congressmen and so forth, to all sorts of other policymakers. So another quick example, almost as long ago, a little over 15 years ago, at GW, you mentioned, I proposed the first ever course in the School of Medicine on obesity. And the deans said, we don't want to do that. There's no point in having a course on obesity that would be, 20 minutes long, just tell people to eat less and exercise more. What we'll let you do is a course on nutrition, and you could talk about, obesity within that. That lasted, and so we did that. That lasted for 1 year, and I focused entirely, essentially, on obesity. And there was such great feedback from the students that were involved that the next year they allowed it to be called a course on obesity. It went from an elective to a course that, an elective with 15 or 20 kids, to a course that was taken by most of the medical school class. And it was driven by, in part, me continuing to educate me and my colleagues to continue educating the deans, and then the kids that were the students that were learning more and more about it, that were further able to go back to the deans and reinforce the importance of this. Without that, there's no way for them to have any insight into this. So, education goes a long, long way. I think stories as part of that education go a long way. I think the video that you showed is really, really valuable. And I think stories like that can really change minds and hearts in a lot of ways.
So Scott, I'm beaming from ear to ear because you said GW 15 years ago, and I graduated from GW Med in 2010. So I took your class. So look, I'm living proof, like what happens, and now I'm an obesity medicine physician and researcher. I took that class, I'm not joking.
Okay, that was not scripted.
We did not plan that.
This is brilliant, we've got proof of concept right here, amazing. But the thing that I like there, Scott, is that you're talking about sort of the individual impact, but obviously the individual impact isn't scalable. It can't be that you're having to go to every single person involved with policy making and go over years. So I think it's really great to hear about that impact of those sort of education level sort of interventions as well. And Amber, I wanted to ask you about this specifically because how can we kind of scale up these education programs? Because, from what Scott's saying, it's not, there's obviously specific settings, medical training, but also, thinking about if there's training within Masters of Public Health, things like that, where moments like that where we can specifically train people up. But broader sort of education programs, what are some of the opportunities there? I know you'd mentioned about a citywide education program, a program that you were asked to be part of,
Yeah, I think so when you see like public campaigns, I think there's an opportunity to make sure that obesity education is part of it. So city I live in had an initiative, which is great, that's focused on health. We are on a mission to lose 1 million pounds. They engaged me saying, we want you to be involved in this. And I asked what their obesity education looked like. And they were like, the what? And not everybody who has excess weight has obesity, but I want to make sure that we're equipping people to understand their health. But I think there's this even on we've talked a lot about policy, and we need the Treat and Reduce Obesity Act passed. I feel like I've been working on that the majority of my life. But there are policy, we all have the opportunity wherever we sit, whether we impact business or healthcare or you're in a nonprofit, I think if you're living with obesity or in any position of power, you have real or positional power that have policies as part of what you're doing. So I think thinking about, yes, we could, if we wait on Congress, we may be waiting a moment. And so I think giving cues to our elected officials is that we're not waiting on you. And so I'm an elected official in Memphis. I sit on our school board. We're the 25th largest district in the United States. We have 13,000 employees. One of the, it's a small policy change, but recently amended, we have a policy about when you travel, this is what we pay for, this is the distance. We added something that said if you qualify for an airline or another travel company's policy, person of size policy, we will reimburse you for that. We have 13,000 employees now who are teachers, coaches, who aren't going to let their professional development opportunities stand by the wayside because maybe they feel more comfortable now that they're going to get those things approved. So that really makes a difference, like making it the default instead of something that people living with obesity have to ask for. So those policies happen all over. Looking at your employer-based health plan, if you don't have anti-obesity medication coverage, you should go to your HR professional and say, why not? That's something we're embarking on in the school system as well, about to put an RFP out. The number of teachers who have told me, this is not covered. So they know, they've heard from me about what I want to see. So you have that opportunity.
Yeah, definitely. And Christy, what's been your experience in terms of any kind of breakthrough moments with policymakers, or what's really worked in terms of trying to get policymakers to understand the issue of obesity and take action on it?
So, Scott brought this up, but personal stories, I think, are the most impactful. And I'm guessing, I've known Amber for a long time, I'm guessing that she got her start mostly in advocating through the Obesity Action Coalition. So they are the only patient-centered group on obesity. And they've been around for, they're just celebrating their 20th anniversary? Or 25th. I'm trying to remember. 20, I think it's 20. And so, the more that we can help train people living with the disease of obesity to talk to their employers, their family members, their doctors, and their policymakers, and they have a wonderful program. It's a wonderful website, Obesity Action Coalition. And so bringing people who are willing to tell their stories to Capitol Hill has been one of our most successful ways of and sort of moving the needle. I also just think that we've gotten to a point, again, like I said, over the last couple years since the new medications have been on the market, where we're finally now going to Capitol Hill and we don't have to educate the staffer, yes, this is a disease. They know now what the Treat and Reduce Obesity Act is. They know that that obesity is a disease, and they understand it. 5 years ago, during COVID, when obesity was one of the largest risk factors for complications from COVID, we were still having conversations that started with, we wanted to, pass the Treat and Reduce Obesity Act, and they said, yeah, but what about like better food and like better, places to exercise? And we were like, yes, that's important. All of it's important, but we want to pass this, legislation, and we just weren't getting anywhere. So I've seen a huge change in just the last 5 years.
That's such a great positive note to kind of end our primary discussion here. To have your experience of actually having seen those conversations changing is really powerful. I'm going to open up for questions in a moment, but just thinking about, you mentioning the OAC there, we're working with them on this program. They've been looking at our index framework, things like that. So again, I think from my perspective, it's really important that I practice what I preach, and that actually we are getting people with lived experience and representatives involved in these kind of programs so that we are, practicing what we preach, basically. But I've got colleagues with microphones if anyone's got comments or questions. We had some of them.
Thank you so much. It's been really wonderful to hear all of the different perspectives that you each bring to the table. My question is really about the big food industries in America, meat, dairy, the big farming, and the sort of huge lobby that we have. You touched on it a little bit in the beginning. The marketing is so predatory. And of course, it's so good that it's so human focused, the treatment, and there's so much sensitivity and awareness now in destigmatizing. But I think that humans, we're vulnerable, and many of the folks who are suffering from obesity are so vulnerable. And so my question is really around, do you think that we have a chance to really push back on how harmful and predatory a lot of the marketing is on our most unhealthy food and the things that we're offering? It feels like such an American-centered problem, and so an American response seems to be important, in that conversation. sometimes I feel like, it's very hard to push back on these huge organizations that have millions of dollars, to lobby and kind of stay in the background. But that's sort of where there's the big opportunity, in my opinion.
Yeah, absolutely. As someone who lives in the UK, where we have quite strict legislation around marketing, especially food to children and things like that, it is quite a noticeable change when I travel elsewhere and things. Amber, did you want to come in?
So just respond, it is not just a US specific challenge. So I sit on the World Obesity Federation's Board of Trustees. And so similar to the sort of state mapping that is happening now, the indexing, we're doing something called MAPS, where we're looking at the entire healthcare system as it relates to obesity. And particularly when you look at low and middle income countries, they have a unique challenge that they have equal amounts of malnutrition of underweight and overweight. And so how do you address systems that have people experiencing it at both ends? And so food marketing is a big part of that. Food availability, and so there are policy changes, but what I will say is to reduce the rates of obesity, it's not just going to be food, but it does have to be part of it. No country in the world has seen a decrease in their rates of obesity. 1 in 8 people in the world live with obesity. We're projecting 50% of people living with overweight and obesity by 2050 if we don't change anything. So we don't have to just change one thing, we have to change it all. And it has to be a mindset that we're talking about sort of the cost or sort of overrunning our healthcare system. If we think action is expensive, we should calculate inaction. And that has to be the mindset.
Yeah, definitely. Thank you. Any other questions?
First and foremost, I want to thank you all for just sharing your wealth of knowledge. I feel like a lot of this conversation, fortunately, has been centered around policy, healthcare, self-empowerment, but I'm sure that each of you know that oftentimes obesity and the act and cause for change can be either stopped or positively pushed forward by the families and the friends that they are surrounded with. So as someone who has people with obesity in my family, a colleague, a friend, how can we support as well as encourage them to take action for conversation in those healthcare settings? Because oftentimes, I'm sure you can unfortunately see that some people won't feel as empowered to reach out if the stigma within their family is disencouraging.
It's really good. Scott.
So a couple of things come to mind. I mean, first of all, studies that are done on stigma show that stigma from family members is among the most prevalent of anyone, only sort of rivaled by stigma from healthcare providers. So it's a really big issue, and as you said, it's something that if we can get past it, can be a very positive and empowering place for family members, or if not, it really can be damaging. I think, again, education goes a long way, and so, right off the bat, I mean, I'm assuming this is being recorded and is going to be available publicly. I think this is a great panel to show to your family members, how we can think about obesity in a supportive way, in a way that is not blaming of the person, in a way that is empowering for people either to talk to their doctors or to seek out new providers. And there's a lot of, nowadays there's a lot of good resources like that out there. So you don't have to rely on yourself just trying to convince someone in your family to think differently, but you can use these kinds of resources, these kinds of stories to back it up. And that's the way that I would start.
I also think about ask and don't assume, because again, talking about the emotional aspect, the hard thing about weight, like we even saw with Lorenzo, he had lost 100 pounds. So we should never assume we know someone's story just by looking at them. And we need to also make sure our family member is in a place where they even want to talk about this, because it can be very damaging, as you said. What you may perceive as helping them may actually be hurting them and contributing to their trauma. So I would ask and not assume, and maybe even frame it in a different way, that it's not even about weight, it's about health. How are you doing? For a lot of us, like I'm an emotional eater, a stress eater, like that's when my weight is going to fluctuate. Like, but really it's not the issue of what you're seeing externally, it's like what's going on internally that's driving it. So I think asking and not assuming is just how I would summarize Amber.
I was like, retweet. That was exactly what I wanted to say. Is that like, you can also just, I think any conversation that's hard is approach it with, I love you and I care about you, and what I'm about to say I know can feel bad, but I've learned a lot, and so I want to have this conversation. If you know you have a friend or family member who is ready and feels alone in it, I mean, I have an identical twin sister who has also had bariatric surgery, and she's like, will you go with me to see my surgeon? I was like, I would love nothing more. And he's in the room, and he was like, are you a medical professional? I said, I'm not, but I do a little bit of advocacy. He was like, a little bit? So like having somebody in the room, if you know they are paralyzed by asking those hard questions, be an advocate literally in the room for them, and like ask them what feels hard about it if you know they are ready for care. So just ask how you can show up.
Yeah, lovely practical advice. Got a question over there.
Hey everybody. Also, thanks for having me here, because this is amazing. I'm coming from a obesity adjacent from the diabetes world. So all of the stigma and stuff that goes with it goes hand in hand as someone who lives with it. One of the things that I've found challenging is our best friend's insurance. And it took me over 9 years to finally get a treatment plan that worked for me. And in 90 days, like my numbers changed drastically. I was one, going to an endocrinologist, which nobody told me I was supposed to see. And two, the medication options, which insurance was like constantly having to get authorization because they wanted step therapy. And so one of the biggest challenges that I've found in all of these kind of stigmatized diseases is there's a solution there, but they want you to go through so many hoops to get to it. So what can we do as patients and as advocates to go to these companies and say, hey, I get this is expensive, but kind of to your point earlier, it's more expensive to not. So what can we do to kind of fast track these options? Because spending 9 years on metformin was hell, okay? It was not fun. And it took 2 medication changes to drop my numbers to normal. So that's 8 years that I spent out of control because nobody gave me the tools and the information of these medications work. And now it's everywhere, and there's marketing of around, oh, join this program, but I've got to spend $500 a month when I have insurance who can knock it down to 20. So how do we get those companies to pay attention to that and help us out in beating this by, hey, just cover what we need?
Yeah, firstly, thank you for sharing your experience, because exactly as we've been saying, it's hearing these kind of experiences that makes it real and stops it just being a kind of theoretical conversation. Christy, I know you've worked a lot in this and you're very passionate about it.
Yeah, so we started doing research looking at state Medicaid and state employee health plans over the last 15 years or so. And through that process, we began to realize that when you start to look through health plan documents, there's no consistency there in what obesity treatment is available and covered. And so from that, we then developed an evidence-based comprehensive obesity benefit sort of recommendation. And so that's up on our website. And one of the tools that we have there is it's sort of a way where you can go through your health plan and look and see how it tracks with that comprehensive obesity benefit. And so we often recommend that people then take that and go to their HR or join your benefits advisory committee if you have one at your employer, that kind of thing, to sort of advocate for including these benefits. I also think we haven't really talked a lot this morning about sort of all the other comorbidities and other conditions that come along with obesity or are a cause of obesity. And so if you can sort of get the data and advocate and say, if my obesity is not treated, I have a risk of then having type 2 diabetes or cardiovascular disease or osteo conditions, and all of there's just so many of them, and that's going to cause it's going to be more expensive for you to treat that than for you to treat my obesity, which there are evidence-based treatments as well. So that's on the Stop Obesity Alliance website, and it's a great tool there.
Yeah, that comprehensive kind of economic argument is really, really hard to make. And I know we had another question over there. We are going to close after this question, but we've got time for networking. We're all going to be around, so there's plenty of time to have really interesting conversations afterwards. But our final question, please.
Well, thank you so much. This was such an informative session. And yeah, I think this is perfect for me to kind of segue into the last question is, what I loved about this panel was that there was the word healing in the title. So I'd love for you to comment on what healing looks like for people living with with obesity, but also, weight bias and fat phobia is just so pervasive in our culture. So what does healing look like for people that are not living with obesity as well? Because I feel like it's a two-way street around this conversation.
Great final question. Who wants to tackle it first?
I can start with it, and then feel free everyone to piggyback. So I think about the difference. I thought a lot about this in the last few years, the difference between treatment and healing, right? Treatment is what many of us were taught to do. There's a medical condition, and this is how you prescribe it or the solution you give for it. Healing deals with the whole individual. It deals with the body, the mind, the spirit. And so that requires that we go beyond just looking at the physical ailment we're treating and really thinking about psychologically and even sociologically their relations. How is that interaction? And do they feel like there is, and I'm trying not to talk too woo-woo, so I hope I can put this in a way that you all
Come on, we're at South by Southwest.
Yes, because I do feel in these spaces sometimes, they're like, oh no, she's talking about spirit. So, okay, so, no, but honestly, it is a way that the person feels complete and they feel at one and they feel like they are their best self. That to me is what embodies healing in obesity. And really, when the practice that I had shortly before joining Lilly, that is what we really worked to do, and I saw it. Often people would come and they were focused on the number on the scale, but we would then dive deeper. Sorry, I'm getting choked up thinking about some of the people, and there would be things like childhood trauma that had never been addressed, which we know is associated with obesity. There would be broken family relationships, which I know. And so at the end, their healing was that they were able to see themselves as more than the number on the scale, and that they were able to show up as their best selves in the world. And that is what I think is my hope for everyone living with obesity. And treatment is a part of it, whatever, pharmacological, surgical, those other things, but the other aspect of it can only be when those other components are addressed as well in our planning. So I'll yield there.
I think it's healing for me is feeling worthy in every space, not just a medical space or when I'm getting care for my obesity. It is unlearning the stories that I had internalized about what other people said about bodies like mine and saying that's not true, and I'm gonna show up. And when I started showing up like that, I faked it, and now I feel it. And so until you feel it, that's when you get healed. And I think to the other part of your question though, is like, if you're not living with obesity, what can you do? When you hear something, say something. It does impact, when people know it's not socially acceptable to talk or behave or not act even, from people who don't appear to have sort of skin in the game, right? You start to change their behavior, and then you create more healing environments for everyone, but you also create really an appetite for policy change. This is I think what we're talking about here is if that's how we understand stories, right? Like if data were going to drive policy change, we would have universal coverage already. We don't have universal coverage because we're lacking a social movement associated with it. And I think the question earlier is like, we have to coalesce voices, not just in the US, but globally, about what the impact is in living with obesity. Because if you walked into your healthcare provider's office with an A1C of 7 or 8, and you walked out and said, just make sure you're eating good and moving your body, and you didn't get active treatment, that's malpractice. We have effective treatments that exist. And so how common it is to not get treatment is we want to wake up and that no longer be acceptable. And that change, and how we show up as people with lived experiences, I think, are what's actually going to drive that after government.
Thank you so much. And I think one of the things that's really come out through the conversation today for me is the importance of education, but across the board, it's something where we need to educate our societies very broadly, as well as having the specific courses that Scott's delivering and things like that. So it's really just about trying to change the way that our society views obesity and people living with obesity, but also understanding the science behind it and how the sociological, environmental and economic factors all play into this and countering those harmful sort of narratives and things. So I think there's a lot of work around education, definitely, in terms of those individual and broader things. But I think also each of us taking responsibility as well in terms of sort of what our individual roles can be. And I guess one of the things that I would close on before we've still got plenty of refreshments, so please everyone help yourselves and continue the conversation. But it was what you were saying earlier about making things the default. So actually it's great to talk about empowering people, but what if we could change it so that people didn't have to ask, people didn't have to be empowered, people didn't have to walk in there with tools and sort of arguments that they've already written down and things. That, for me, would be a real indicator of success. So thank you so much to our panel. Thanks to Lily for sponsoring this event, and thank you all as well.